Dana, and I'm so excited to announce our next presenter, Dr. Camille Moreno. Before I do, though, I wanted to bring your attention to your agenda for just a second. I forgot to mention. There is halfway down the page, it says, if you have a question that you don't feel comfortable asking out loud in front of the group, you can text it to this number, and Bobby will be watching the phone, and she can ask the question for you. So just know that's available to you if you prefer. And Dana, thank you for acknowledging that this is Rise and Reignite. I never even said the title of the conference, so thank you for that. Okay, so Dr. Moreno is here. She is an OBGYN at University of Utah. She's the medical director of their Midlife Women's Health and Menopause Medicine program. She is a superstar. She is in high demand, and we love her. We have learned so much from her about hormone therapy, perimenopause, menopause, bone health, sexual dysfunction, vulvar symptoms in high-risk breast cancer patients and breast cancer survivors. She is phenomenal. She's spoken at our conference before. She's also come up to retreats on Sunday mornings and offered a medical Q&A for our more intimate groups, and we're just so honored to have you here, Dr. Moreno. And without further ado, come on up. I'm going to get your presentation here. Yes, please clap for Dr. Moreno. Yes. Charles, how does she advance it? Just on my screen here?
I can do it. Yeah, thank you.
Okay.
Thanks, Charles.
How do we?
So I'm going to do this.
Thank you. You probably know how to operate this better than I do.
Thank you. Yep, perfect. Thank you so much. Thanks, Allie, for that very thoughtful introduction. I do have a set of slides, so I'm not going to be as exciting as Dana in walking around the room, but I hopefully can make these slides just as exciting as her session. But I'm actually a trained family medicine physician by background, but I do work for the OBGYN department as their menopause specialist. So after I did my family medicine residency, I did a 2-year specialty women's health fellowship that focused on menopause medicine and midlife women's health care. And so I ended up with a position here at University of Utah. But thank you for the invitation, for having me back. It is truly an honor to be here in front of the Image Reborn community, who continues to motivate me and inspire me to do the right thing and to keep showing up at work in the setting of midlife women's health care. And so again, thank you, Allie, for that thoughtful introduction. And so I would like to start us off by sharing a brief overview, as well as a few realities that I want to share as to how women or individuals with cancer or after cancer truly experience perimenopause and menopause. So as you all may know, the average age of menopause in individuals living in North America is about 51 to 52. And every woman with functioning ovaries will experience menopause if they live long enough. But it is very different for women who have the history of cancer, whether it's breast cancer, ovarian cancer, uterine cancer, or really anyone who goes through chemotherapy and radiation therapy. And so cancer treatments overall can induce what we call early menopause or even premature menopause, which I will define those terms here shortly. And going through menopause at such a young age is associated with truly bothersome and severe symptoms that affect your quality of life on a day-to-day basis. And that is something that I am passionate about, is education. So what can we do about those symptoms, right? What can we do about those symptoms that affect the relationships we have with our families, our partners, and even at work, right? Because we do know that menopausal symptoms are very costly. And also, keep in mind that going through menopause early is associated with the development of chronic health conditions like type 2 diabetes, insulin resistance, heart disease, and even osteoporosis and an osteoporotic-related fracture. And so it is important to treat not just the cancer, but the menopausal symptoms and all those chronic health conditions associated with having the cancer, right? And it is important to treat the patients. It is important to treat the survivors. But it can get very complex and complicated easily. And unfortunately, some of these symptoms, people's narratives, lived experiences, are oftentimes neglected. So, welcome to Perimenopause and Menopause Preparedness, where today, it starts today, we're all prioritizing awareness, education, and empowerment. We're hearing the word empowerment because I do think knowledge is power in many ways. And I always like to start us off by sharing this, right? This is your time, your knowledge, and your space to educate yourselves and become your best advocates. So starting us off with a basic review of the 3 stages of midlife. So that includes perimenopause, menopause, and postmenopause. So perimenopause refers to the stage in a woman's life that happens 7 up to 10, maybe on average 8 years before the average age of menopause, so before a woman experiences her last menstrual period. And this is the stage of life when estrogen and progesterone levels start to decrease and symptoms start to become more noticeable. And then menopause happens, and that is defined as 12 consecutive months or 1 full year of no menstrual bleeding. And at this point, your ovaries are no longer producing your estrogen and progesterone, which are your sex steroid hormones, and you're no longer getting your ovulatory cycles, right? And so you're no longer producing or releasing the eggs. Postmenopause happens literally the day after your last menstrual period and lasts for the rest of your life. And this is actually where symptoms start to ease up because you're faced with hormonal levels that start to settle. They become more stable. So there is that light at the end of the tunnel where symptoms do get better eventually. It's just a matter of time, but it's very different for different women. And as you see here, the different symptoms and the variety of symptoms on this slide during these different stages, and they all start in perimenopause. And we will go through these symptoms in the next few slides. But before that, diagnosing menopause after cancer or going through cancer treatment, whether it's chemotherapy, being on an estrogen blocker, or radiation therapy, can truly be different. And in patients who are younger than about 35 years old, about 70% of them will actually resume menstrual cycles within 2 years of receiving their chemotherapy. So you may be told that your ovaries are no longer functioning, but then years down the road, all of a sudden, you get this random bleed, right? And then this is very confusing for most women. I promised earlier that I would define what these types of menopause are that affect women with cancer or women living through cancer treatments or with cancer treatments. So premature ovarian insufficiency is also called or referred to as premature menopause. And this is basically defined as when you get your last menstrual period before the age of 40. Early menopause refers to women who get their last menstrual period between the ages of 40 to 44. Okay, so those are 2 different definitions. And asking simply when your last menstrual period is how we define these types of menopause. But there are labs, there are hormonal labs that we can get to help suggest, not necessarily confirm, because there are no labs to confirm your menopausal status, but it can provide us with a little bit more information. And so you see here, FSH, which is called follicle stimulating hormone, is one of those labs that we use. And if that level is greater than 35 to 40 or higher, then that is suggestive of menopause. So that can help. And then anti-Mullerian hormone, or AMH, can tell us more ovarian reserve, not necessarily the quality of your eggs, but it also does not predict fertility. I actually ordered my first, what I call PICO AMH, which is a specific lab test. It's also called MenoCheck. And this is actually available in certain labs, and it can predict within the next 5 years if you will be transitioning into menopause. We used to actually use that only for research studies, but ARUP has had that available for patients and for providers to order within the last year. So that is another lab. So you see here a list of symptoms. I call them cluster of symptoms, right? Because it's truly a cluster. So if you are experiencing perimenopausal, menopausal symptoms, it can feel like they're all over the place because there are estrogen receptors found ubiquitously, found all over the body from head to toe. So it is not just our reproductive organs that have estrogen receptors like our breast or ovaries or uterus, but even our neurotransmitters in the brain have estrogen receptors. Our muscles, our retina, our bones have estrogen receptors. So let me go through this list by system, okay? Because I am a systematic thinker. And so the symptoms that affect the brain typically have a lot to do with hot flashes and night sweats, which you all know are classically symptoms related to losing your estrogen. And these hot flashes and night sweats can cause sleep interruptions, they can cause cognitive changes, so slowing like brain fog, lack of focus, lack of concentration. When you're not sleeping well, you're gonna feel like crap the next day, you're not on top of your game, you feel a little bit more tired, you feel like you're surviving, right? You're just surviving the day. And then there's also the loss of estrogen and testosterone and its impact on your metabolic changes. Once we start losing estrogen, the risk for these risk factors for heart disease also increase, and that is the risk for insulin resistance, cholesterol changes, as well as blood pressure increases. And those are known risk factors traditionally for heart disease. There's also that reality that losing your estrogen and testosterone can cause some central weight gain, right? So it's all in the belly area, unfortunately, which is hard to get rid of. And that has a lot to do with the rise in cortisol levels, which is a stress hormone. So when you're not feeling like yourself and you are not sleeping well, you tend to have that rise in cortisol and rise in stress, which is attributed to this. The genitourinary system also has estrogen receptors. So that is more than just sex. That is more than just the vagina, the vulva, but the bladder has estrogen receptors. So once you start losing estrogen, the risk for urinary tract infections start increasing, okay? Including UTI-like symptoms like burning, frequency, urgency, leakage, or incontinence. So it is more than just painful intercourse. It is more than just vaginal or vulvar dryness. And the vagina is not the same as the vulva. The vulva is the skin outside of the vagina, and the vagina starts with that opening into the vaginal canal. So two different areas we're talking about, but have a lot of estrogen and testosterone receptors. Our skin, our hair also have estrogen receptors. So once we start losing estrogen, we also start losing collagen production. And when you lose collagen, that reduces elasticity, it reduces hydration, it increases dryness everywhere, and it also increases wrinkling. So it is more than just living here in the state of Utah that's dry all the time, even in the winter. So it is also influenced by your estrogen receptors along the skin. Sex, right? We have a lot of good sex lectures today, but there is an influence of losing your testosterone as well as the effects on sexual function and in libido, so I'm not gonna go into that. Dr. Rulo follows me, who's the expert in this. And our musculoskeletal system, that also has estrogen receptors. So there is an emerging term or medical terminology called the musculoskeletal syndrome of menopause. Mind-blowing, right? And so this includes generalized joint pain, restriction of your joints with certain movements. You may be experiencing frozen shoulder. What the heck is that? That is part of musculoskeletal syndrome of menopause. So there's a lot of influence of estrogen. So what are the typical symptoms? Vasomotor symptoms is just that fancy term that refers to hot flashes and night sweats, which can accompany perspiration, chills at night, even heart racing, causing sleep issues. Heart racing, I know, what is that? Why would I feel heart racing during the nighttime, right? Before I go to bed. That is actually a true physiological response that's affected by your thermoregulatory zone that's located in the brain, specifically the hypothalamus. So before you even have a hot flash, you may experience that heart racing. And unfortunately, hot flashes last anywhere between 7 to 10 years. They're long. They're not just a weekend thing. So it is unfair for us to tell you just basically put layers on, remove layers, maybe put some socks on while you're in bed. Those are unfair statements to make. They're very long duration of symptoms that women go through and experience. And they can be most intense and most frequent anywhere between the first 3 years before your last menstrual period happens, or in the first, or after the first, or the first 3 years after that last menstrual period happens. And so eventually they will go away and they will get better, becoming less frequent and less intense. So sleep. Sleep is a big problem that I often hear about, and it is more than just hot flashes and night sweats causing sleep interruptions. It could be related to aging in itself, and there's that physical effect of aging, right, that we can't change. We get older each year. There are also stressors and psychological factors like anxious thoughts that keep women up at night. That also can cause sleep interruptions. Medical conditions like, again, musculoskeletal syndrome of menopause and these chronic pain syndromes that can wake you up at night if you move to one side of the bed and that right hip aches. That's going to wake you up. And so that might be a trigger, and it's hard for you to go back to sleep after that. Certain triggers like alcohol use also can cause sleep interruptions and overall poor sleep habits or poor sleep hygiene. But I want everyone to note that, again, it is more than just the hot flashes. About 51 to 52% of midlife women will be diagnosed with an underlying sleep apnea or restless leg syndrome. And so it is important to make sure that we do a comprehensive workup to evaluate for these sleep disorders. And for those of you who are not familiar with sleep apnea can present as more than just snoring, right? You may wake yourself up because you snored yourself up from sleep, or it could be from an apneic episode where you actually woke up because you were gasping or choking for air, or it could also be waking up tired. You don't feel like you got a restful night's sleep. You already felt fatigue even before getting out of bed, and also waking up with a headache. So those are important signs and symptoms to think about when it comes to sleep. You may need a sleep study to help evaluate or rule out sleep apnea. And restless leg syndrome is a condition where you actually have to physically get out of bed because you have these lower extremity or leg sensation to get out of bed. So either it feels like your legs are itching all the time and getting out of bed makes that feel better, or you get this uneasiness in your legs where, again, that triggers you to get out of bed, and that typically helps symptoms. So that is something to be aware of. Mood swings also are common, and I typically hear more about mood swings and worsening anxiety and depression, especially in perimenopause. Because in perimenopause, again, that first stage of your midlife years, right? You're dealing with the up and down swinging of your hormones, and this is what we call the hormonal milieu. And so when you are dealing with the up and down swinging of progesterone specifically, that has a lot to do with your mood. And also has a lot to do with migraine intensity and migraine frequency, especially if you're dealing with a drop in estrogen concentration, which typically triggers a migraine or a headache episode. And so that's the next slide. But women who are most vulnerable to depression and anxiety during their midlife years also have a history of postpartum depression, maybe PMS or premenstrual syndrome, or PMDD, which is the more intense version of it, which is called premenstrual dysphoric disorder. So joint pain. I mentioned musculoskeletal syndrome of menopause, which I know menopause can influence, how severe and how frequent these symptoms can be. But also keep in mind that vitamin D deficiency or low vitamin D levels, especially in the wintertime, can cause generalized joint pain. And autoimmune conditions and connective tissue disorders are also highly prevalent in women, and especially diagnosed during the midlife years. And so again, pattern recognition of your joint pain is important. It can feel like the joints are hurting all over the place, but it is important to pay attention to, is it just my small joints, large joints, a combination of both? Is it symmetric, one-sided? So it starts with that history. I mentioned weight gain earlier and how hormonal deficiencies can affect midlife weight gain, and that has a lot to do with slowing down of our metabolism, right, as we get older, but also the influence of poor sleep, right, causing even more of a slowdown of our metabolism and decrease in our resting and total energy expenditure. But on average, when women enter perimenopause, so the start of their midlife years, there's about a 12 to 15 pound weight gain. So that's about 1 to 1.5 pounds per year. And that weight gain typically is more centralized or can accumulate around the belly, which we know otherwise is belly fat. There is more than just the appearance of that weight gain, right? We also know that visceral fat and subcutaneous fat are risk factors for heart disease. And so paying attention to those biomarkers, what are my cholesterol labs, what are my diabetes screening labs looking like in the last couple of years as I enter perimenopause, those are helpful information. And there are also specific lipid biomarkers that are influenced by your genes, your genetic markers that are not attributed to lifestyle, dietary habits, or movement. And this is lipoprotein A, apolipoprotein B, and so those are important cardiac or heart biomarkers to also pay attention to. So you may have seen this last year. It was published in the New York Times last summer that truly stated that menopausal symptoms is very costly to America. It costs the US $1.8 billion annually because of loss of work productivity, because of midlife women who make up 50% of the workforce in the US experiencing these menopausal symptoms, right? So increase in absenteeism and presenteeism are real problems. And so, again, it is important not just to prioritize quality of life, but also all around, right? Our executive functioning that happens to be either at work, when you're taking care of your family members, you're in the sandwich generation, maybe taking care of children who are still dependents living at home, or aging parents who also have their own health conditions. But I don't want to sound all gloomy, right? Because the first half of his lecture seems like, oh my goodness, it can affect so many things. But I want to end with, there are symptoms, treatments for your symptoms. Symptoms are real, but there's also treatment options for those real symptoms. And so I want to provide some information and some education on what these can be. And for those who have a history of cancer, again, it doesn't just have to be breast cancer, but since we're in a breast cancer conference, we will focus on that today. But there are still many, many, many ways to help manage these symptoms. It is not a complete no, okay? There are still lots of tools in your toolbox that you can talk to your healthcare provider about. So this is just a summary slide of prescriptions versus non-prescriptions. We will talk about the prescription therapies in more detail in the next few slides. But as far as non-prescriptions, cognitive behavioral therapy, or CBT, has actually been shown to have level 1 evidence for managing hot flashes and night sweats, and that is endorsed by the Menopause Society, which is a nonprofit organization training providers for menopause care. Clinical hypnosis actually also has level 1 evidence, as well as foods rich in what we call estrogen, right? Estrogen-like compounds that are often plant-based, like soy. Few have been on or taken a soy supplement or black cohosh, this is what I'm referring to. And then there's also stellate ganglion block, right? What the heck is that? So it is basically offered by an anesthesiologist, and there is local anesthesia that gets injected into your cervical spine, so basically your neck area where the stellate ganglion is located. And the stellate ganglion has a lot to do with our sympathetic nervous system. And so when you have increase in sympathetic drive, that typically triggers the hot flashes and night sweats, but when you actually inject it, you calm the nerves down. So it can also calm the hot flashes and night sweats. Although the level of evidence with this type of treatment is poor. Behavioral modifications and lifestyle, I always say, are foundational because these are the things we have control of, right? And so avoiding the hot flash triggers, it can be variable. It could be the glass of wine, it could be spicy foods, it could be hot yoga, I don't know. But there's so many triggers, and knowing your triggers is important. So we all know this, right? Eating a well-balanced diet, moving more, right? Using physical activity, not just as a de-stressor, but also for heart disease prevention, right? Also for hot flash prevention and management. And maintaining a healthy weight, avoiding smoking or tobacco use, managing stress, and improving sleep. So these are overall the generalized guidelines that we have control of.
Can I ask a question about
Yeah.
that before you move
Sure.
to the slide?
Please, yeah. How do I go back? Oh,
Looking
God.
at that, is there anything in particular to be preventative for the restless leg syndrome? Like stretching or different exercises that particularly target that area?
Yeah, that's a great question. So,
Right.
yes. Thanks for those great questions. So, for restless leg, typically we want to evaluate for deficiencies, and the most associated deficiency is actually iron deficiency or iron deficiency anemia. So checking your CBC or hemoglobin levels and ferritin levels are important when evaluating restless leg and making sure you're getting enough dietary iron. But if you are not, then getting an iron supplement, a ferrous gluconate supplement is what I would recommend because it's less constipating. So stretches are good. Sometimes a foam roller, if you have access to that, they're actually pretty cheap, less than $10 at Sierra. And so foam rolling your thighs, your back of your calf, right? It might hurt at first, but it actually will feel good later. So doing 10 minutes of stretching and foam rolling will help with that as well. And magnesium. So there are some of us who maybe sweat all the time, like me. My armpits are sweating at the moment. And we may be a little bit low in magnesium. And so maybe taking a magnesium supplement, again, consumer beware with supplements just because there's no FDA oversight, but be your best consumer advocate when choosing supplements. Yeah.
I have restless leg.
Oh, okay.
There's different types of magnesium.
Yeah.
So do you know what's
Helpful. Yeah, another good question. So magnesium glycinate and magnesium threonate are the ones I do recommend because they can help with sleep. Although, again, the data is not as robust. It's often mixed when it comes to sleep and magnesium supplements, but those are the ones I would recommend specifically. Glycinate? And threonate. Yes.
So the question I have is, we've gone through some of these hormonal options.
Yeah.
The challenge we have is, you can't answer this because you're not in the insurance industry. 90% of that
I
is
know.
not approved.
Yes.
So like you go in, you're like, hey, I want to try this. No, sorry, denied.
Yeah.
No, sorry, you got paper out of the box.
Absolutely. You're speaking my day-to-day life at work. Yeah,
I know you have your challenges too, so.
yeah.
And so I don't know if it's, maybe a prescription, maybe something else.
Yes.
Obviously, maybe a way to track it, okay, these are checking your insurance.
Yeah. Yeah, great question. We will talk about that too in more detail, but there are savings cards or support cards, depending on who's making that prescription therapy, that you can kind of search online. So the new medication called Veoza, we'll talk about here later. There's a veoza.com, and there's a tab specifically for consumers or patients, and you can click on that, and that's where you can access the support card. But you're absolutely right. It depends. And there's other other ways you can go through this, like Cost Plus Drugs, which is Mark Cuban's pharmacy. They have like a 4-page formulary, and there's some prescriptions that are covered related to menopause, but others not. And then there's GoodRx, right? So there's savings cards through GoodRx that you can also present to your pharmacist. You just want to make sure that they're running that prescription cash price and not with your insurance plan. So you can actually use the GoodRx coupon. So menopausal hormone therapy, yay or nay, right? When is it safe to use, and when is it not safe to use? So when is it acceptable or not acceptable? So this is actually a summary slide that I borrowed. I don't like saying stole, but I borrowed from my colleague which cancers or types of cancers are acceptable with hormone therapy. And so as you see here, overall, we tend to avoid menopausal hormone therapy in those who have breast cancer diagnosis. But if you have an estrogen receptor negative breast cancer, we could potentially offer you menopausal hormone therapy, and we'll talk about those options here later. So just a quick review. This is a list of those indications of when do we start menopausal hormone therapy and for what indications. It's still the most effective treatment option for hot flashes and night sweats, and no other pharmacological treatment and no alternative treatment surpasses the effectiveness of menopausal hormone therapy. We also use it for prevention of bone loss and prevention of osteoporosis. We know that it reduces fractures, specifically hip fractures. We also treat women who go through premature menopause, as I explained earlier, in early menopause, especially when you get both ovaries surgically removed and you undergo risk-reducing surgery with a mastectomy. It is important to replace your estrogen in this population of women because we are taking your estrogen away almost a decade before the average age of menopause. So it is detrimental to replace it in that population.
So, my oncologist, I know you're not going to give me medical advice, but I just
Yeah.
need a little bit of a clarification. No? I can speak loud. So, it's mostly for the recording. Oh.
I know.
Hello. There we go.
Nice.
Okay, so I'm double positive. Just recently had a hysterectomy, so that all the estrogen, all the stuff can be taken out. And I'm being told I can't have any of that. So how, like, if I'm supposed to be, how am I supposed to be doing both?
Yeah, and I'm assuming both ovaries were removed as well in your
Yes,
case.
absolutely.
Yeah. It depends on your age when you went through the surgical menopause, right? Because if you had spontaneous menopause first and then ovaries were removed, then they typically won't offer estrogen replacement. But if you had premature menopause when both ovaries were removed before the age of 40, also underwent mastectomy, then this is actually the population where we would want to replace your estrogen for the brain protection, the bone protection, and the heart disease protection.
So basically, if I fall in the front side of that, I'm just, excuse the word,
Not
I'm boned. Like I'm literally screwed. Is that what
So-
I'm hearing?
Yeah, so great question. So it depends on the type of cancer, right? And the staging of cancer, your oncogenic type, right? So did you have to go through chemotherapy because your oncotype was high? And are you at least 5 years out of your diagnosis? So maybe that breast cancer recurrence is a little bit lower compared to the first 5 years. Those all come into play. And we typically do offer non-hormonal options first for symptomatic women. But if you've tried literally 7 things on the list and you're coming to me, tell me what my other options are, we could potentially try what we call a tissue-selective estrogen complex called Duave, which actually does have estrogen with basidoxifene. And currently, Duave is being studied in DCIS patients, and it's called the PROMISE trial, PROMIS. University of Utah is one of them, and that is what they think is a little bit safer at the level of the breast tissue and may not increase breast cancer recurrence. So
Thank
that
you.
might be an option.
Thank you.
You're welcome. But those are for women with a uterus, okay? So just an FYI, we'll talk about that later. So not everyone is a good candidate for hormone therapy. This is just that list, right? So as you see here, estrogen-sensitive cancers is a contraindication, but also risk factors including high risk for blood clotting. Actually, you're not good candidates for hormone therapy if you have had a blood clot, whether it's in the leg or the lung, or you have a family history of blood clotting. Same with having history of a stroke, heart attack, that's the MI or myocardial infarction. Those individuals who have that history, unfortunately, are not great candidates for menopausal hormone therapy.
Sorry, real quick. Have you heard of factor 2?
What is that?
It's like a blood clotting disorder.
Oh, yes, factor 2 deficiency. Yeah. So this is where it gets a little bit more tricky and very individualized. So if you actually have a factor 2 deficiency mutation, the more common one is factor 5 Leiden. There's also prothrombin mutation. So if any of those ring a bell, and if you actually have never had blood clotting yourself, then we can still talk about hormone therapy, and especially if you just inherited more of a heterozygous mutation versus a homozygous mutation. But if you've clotted having a factor 2 deficiency, then that is something I would say would be a contraindication to menopausal hormone therapy.
Thank you.
And we'll talk about safer options too. There's transdermal options, which are the patch, the gel, the spray, the vaginal ring, which don't go through the liver. So those formulations actually bypass the liver, which means they don't increase the stimulation or production of those blood clotting factors or inflammatory markers. So as far as clotting history or at risk for clotting history or at risk for clotting because of your history, that would be a safer option to offer. So this is Duovay that I talked about. Typically the basidoxifene combination with estrogen. That's exactly what Duovay is made out of. And basidoxifene actually has been shown to be an antagonistic compound at the level of the breast, while an agonistic compound at the level of the bone. So initially, basidoxifene was studied for bone or osteoporosis treatment, and actually not for hot flashes. And then when they combined it with estrogen, they formed the TSEC, the tissue selective estrogen complex, and that is what is being studied right now, like I mentioned earlier, in DCIS patients. So it's what we call a SERM, an estrogen receptor agonist antagonist. So what are your non-hormonal therapies? We just talked about a whole laundry list of those individuals who are not good candidates for menopausal hormone therapy, including having hormone receptor positive breast cancer, right? So Veozah, I mentioned earlier, we call this fezolinetant or Fezo for short. It has been available in the market since May of 2023. And this has an FDA-approved indication for hot flashes and night sweats. And it works at the specific level of the brain, again, the hypothalamus, which I'm bringing back up again. And when you start losing your estrogen, there are these specific receptors in the brain called the kisspeptin neurokinin dynorphin receptors, or what we call KNDy neurons for short, KNDy. So when you lose your estrogen, these receptors increase in size or hypertrophy. And so what Fezo does is it blocks specifically at that KNDy neuron receptor, decreasing hot flashes and night sweats anywhere between 50 to 70% as early as 4 weeks. I was part of the advisory board for Fezo, and we did see some preliminary data before it got approved by the FDA. And it did show as early as that first week, you can actually find or experience symptomatology from Fezo. So women who have liver conditions or liver disease are not great candidates for Veozah or Fezo because it does go through the liver. I think I saw a hand raised. Yeah. Yeah, great question. So there was one case out of 79,000 cases where Fezo did show a bump in liver function testing. And since it is the newest prescription with this novel mechanism of action, the FDA is very cautious with it because of that one case that actually normalized after stopping Fezo. we do, as providers, have to check your liver enzymes prior to starting it every month for 3 months, at month number 6, and at month number 9. So it's a lot of liver testing. So any liver injury or liver condition, right, can present with jaundice or yellowing of the skin, right upper quadrant or abdominal pain, nausea, GI disturbance. So those would be the side effects. Great question.
Question about follow-up on that. Tamoxifen use
Yes.
with Veoza or Fezo.
Yeah.
Are there any contraindications there?
Great question. So currently it's in phase 3 clinical trials, and these are patients who are estrogen receptor positive on tamoxifen or an aromatase inhibitor like Arimidex or anastrozole. And these patients currently are being studied on Fezo for hot flashes and night sweats. And so far, what they've seen is no interaction between the two. So it doesn't decrease the concentration of tamoxifen in patients who are taking them. Yes.
Wanted to mention that we are doing the fatty liver screening. So we do the complete metabolic panel.
Nice.
We are doing an elastography and a body composition. So for
Great.
the recording, we are doing the screening for fatty liver, so that detects if there is fat, fibrosis, cirrhosis. We are trying to prevent cancer, but also because of the chemotherapy and all the secondary effects of all the treatments and long term, I think it's a good idea to have a check. So if anyone is interested, ask me. I'm in the right next to the door at the end.
That sounds good.
Thank you.
Thank you. Yeah, so thanks for sharing that, by the way. So just to extrapolate on the tamoxifen question, so there are certain SSRIs that shouldn't be given with tamoxifen because they do decrease the active metabolite of tamoxifen called endoxifen. So tamoxifen doesn't work well in these cases. So those are SSRIs like paroxetine or Paxil, paroxetine mesylate salt or Brisdel, sertraline, as well as Wellbutrin. So those are specific antidepressants, which as a whole, as a category, we do use off-label for the management of hot flashes and night sweats for those individuals who are not great candidates for hormonal interventions. But there is only one SSRI called Brisdel, again, that's paroxetine mesylate salt, that is actually FDA approved for hot flashes and night sweats, while all the other medications that you see here on the list are not. We use them off-label. There's also another category of antidepressants and anti-anxiety medications called SNRIs, and those are Effexor or venlafaxine or desvenlafaxine or Pristiq. And those actually also have been shown to be effective for hot flashes and night sweats. So you see oxybutynin as an option. And for those of you who are familiar with oxybutynin, this is actually a bladder medication, right? It's for overactive bladder with associated urinary incontinence, but we actually also use it for hot flashes and night sweats. And so it has been shown to be effective up to 70% of the time for the management of vasomotor symptoms. But keep in mind, it can dry you out. So it can cause some constipation, some dry mouth, maybe the opposite, diarrhea. And so also, I try to avoid oxybutynin in those who are in their postmenopausal years, maybe older than age 65, because there are some studies that have reported increased risk for dementia or memory loss with oxybutynin use. So also gabapentin is an option. It's a non-hormonal option for menopausal symptoms. And you may know this as an anti-seizure medication or a chronic pain medication, but we do actually use gabapentin as well, mostly for nighttime symptoms, especially if you have sleep issues or night sweats or hot flashes at night that are waking you up. So this is what gabapentin can target. So this is a summary slide of all of those wonderful options that I just laid out. And this list ranks from the most effective that you see here, and MHT stands for menopausal hormone therapy, down to the least effective, which again is the stellate ganglion block, which is that procedure offered by an anesthesiologist. So switching gears, right? We talked about the cluster of symptoms from head to toe, but now we're focusing on the pelvic area, the vagina, the vulva, the bladder, the urethra. We call that genitourinary syndrome of menopause, or GSM for short, which affects over 70%, 50% is an old number, but of postmenopausal women. But especially if you are on an estrogen blocker, estrogen blockers also block the estrogen receptors that are found on the vulva, the vagina, and the bladder. And so the rates for GSM are even higher on tamoxifen and aromatase inhibitor. So it is important to talk about intimacy, sexual wellness. It is important to talk about dryness and bladder symptoms. I know this looks a little graphic, but I want to prove a point here, right? And so on your left is a photo or depiction of a real person with normal anatomy, without GSM, without signs and findings of genitourinary syndrome of menopause. But the photo on the right, as you can see there, everything just looks distorted, right? Everything looks thin, maybe pale. You can tell it's not as lubricated. There's a prolapse that's in the middle of the vaginal canal. The anatomy is not as well differentiated. And this is exactly what GSM looks like clinically when I am examining the vulva, the vagina, and doing a pelvic exam overall. So here is a summary table of moisturizers and lubricants. And just to provide some background on what the heck are those, right? Lubricants are used what we call on demand, with intimacy, whether with a partner, self-masturbation, self-pleasure, whatever, right? And you use this as needed. But moisturizers, you actually have to use this as maintenance treatment options or therapies. And so what that means is you're using it every other night, a few times a week, right, to help moisturize that area, increase a little bit of lubrication and secretion in the vagina. But we know, right, that pelvic floor physical therapy, and I remember when I was here the first annual conference, we had a pelvic floor PT come give the talk. But this is also important because it is more than just the vaginal and vulvar tissues that can cause pain with intercourse. It could actually be the tonicity or the spasming of your pelvic floor muscles causing pain with intercourse. And no estrogen or no lubricants or no moisturizer can help that. It's actually more pelvic floor therapy, right, that can decrease the tonicity and decrease that spasming. So it does take a multidisciplinary team to help with symptoms related to GSM. Some of you have probably heard of fractional CO2 laser therapy. If you've done Mona Lisa, Vivive, those are the ones I'm talking about. And to date, they're not currently FDA-approved procedures or devices, and there's actually an FDA warning against them because it can lead to scarring, adhesions, or contact bleeding with these procedures. But I always say that if it works, it's an option, right? Because sometimes we're running out of options. But keep in mind that the CO2 ablative laser therapy is typically out of pocket. I think you can use an HSA or an FSA for them, but it is about $1,200 per treatment, or for maybe 3 treatments for some of them. So for individuals with really moderate to really bothersome symptoms related to GSM, and you've tried everything, you're on your 8th product, you maybe have good, clean love on your tables right now, and you're like, I've used this consistently, I do not miss a night, and it's still a bothersome issue for me to have dryness, right, pain with intercourse. This is where we talk about low-dose vaginal estrogen cream as well as vaginal DHEA, even in patients with hormone receptor positive cancers. So these are those 2 publications that studied vaginal estrogen formulations in those with breast cancer, specifically hormone receptor positive breast cancer. And overall, the systematic review and meta-analysis did show it is safe. it is safe to use vaginal estrogen products in the vagina for the management of GSM or genitourinary syndrome of menopause because it doesn't increase blood levels of estrogen. Okay? So keep that in mind. And we'll talk about that, what those are and what those options are. Yes?
Anybody after radiation have UTIs like
Yeah.
off the wall?
Yes.
You're not even doing anything at all.
For sure.
Oh crap, here it comes again.
Yeah, great question. So radiation, UTIs post-radiation therapy. Actually, this is where I have to think out of the box because it can be more than just GSM. It could actually be radiation cystitis. And this is where
Up here, goes down there.
any radiation in the pelvis area, so lower abdomen or below, can affect the bladder, the vulva, the vagina, the uterus. So there is such thing as radiation cystitis, where toxic levels of radiation therapy can actually cause kind of necrosing tissues at the level of the bladder. And those are very bothersome symptoms. You may also notice hematuria or literally peeing blood and seeing that blood in the toilet bowl. And I know that's kind of a severe case, right? And overall potentially rare, something to note. So your differential and your things to look out for and to evaluate becomes bigger. Okay?
One more question.
Yeah.
You know that over the counter that ruins your underwear that's orange?
Oh, yeah, Azo.
Yeah. I mean, does that take care of it, or do you just have to play the game at the doctor every time?
Yeah, great question. So Azo is basically phenazopyridine, right? And so it does primarily help to soothe urinary symptoms. It doesn't really treat any underlying bacterial infection. So it just helps that burning with urination, and it can actually make test results inaccurate if you have taken Azo like on the dot or on the clock, and then get a urine testing. So it's important to do urine cultures instead of the just what we call point of care urine analysis testing or bedside testing. Yeah, you're welcome. So you see there are many options, yes. Yeah, that's a great question. So that was a cranberry juice question and UTIs in general. So again, they're actually mostly for prevention of UTIs. If you have an active episode, it may help, right? Maybe placebo effect, but some people tell me that it actually does help. But it's actually the cranberry extract supplement at 500 milligrams that's been studied for UTI prevention, as well as D-mannose supplement. And so again, supplement world can be the Wild West, so consumer beware, but those are the two supplements for recurrent UTI prevention that have been studied. But hydration is key. So if you're drinking cranberry juice, you know, that has a lot of sugar, that actually might irritate the bladder. So I would stick with fluids, water, plain water. You see a list of vaginal estrogen products here. So literally so many. These are all prescription therapies. They're not found over the counter. So you can have the cream, a vaginal ring that stays in the vagina for 3 months at a time, and then you just exchange it for a new ring every 3 months. There's also a vaginal estradiol tablet that you actually insert also intravaginally 2 nights per week. And then there is also a bioadhesive capsule that is inserted intravaginally also twice a week. So many products. And I like to share this slide a lot because, again, these levels don't go up beyond postmenopausal range. Probably the highest strength out of all of those products I mentioned earlier is probably the cream, which I do think is the most effective option. But it can slightly, maybe in the first 3 months after using the cream, increase your estradiol level beyond postmenopausal range, and then it comes back down after the first 3 months. And I actually did levels on one case just because she wanted them, and that's exactly what it proved. It decreased after the first 3 months. I think I saw a hand raised here. Yeah.
I was gonna ask about the ring and how,
Yeah.
does your
Let me see.
provider put the ring in?
Great question.
Is that so?
Yes, you can do either one actually. So if you're comfortable basically inserting kind of like, has anyone had the birth control vaginal ring? It's kind of the similar concept, but this is for menopausal women, right? Not the birth control ring. So it's elastic, it's silicone based. You basically squeeze it in the middle and then you literally insert with your finger inside the vagina. You can do this while one foot is up on the toilet seat, or you're in kind of a decubitus position, like laying on your left side or right side, and then inserting the ring in on your own. Although I do have an 87-year-old, I insert her ring every 3 months. And so anyone can do it. Partners can do it, right? Friends, I guess, can do it. If you're comfortable with a good friend, you know, there's so many people you can ask, actually. And so, so just throwing it out there. So let's see. And I just want to mention vaginal DHEA. So vaginal DHEA is not the same as that DHEA you see in the bottle. That DHEA is not good. Okay, I know they're found over the counter. I know everyone, when they come to see me, is on oral DHEA for some reason, but this one actually can hurt your liver. It does go through the liver. Some people say it's for libido, for energy, but oral DHEA, more than 25 milligrams, can hurt the liver. So what I'm talking about here is vaginal DHEA, which you see on the left side, and that's called intrarosa or prasterone. And actually, it's very underutilized, in my opinion, maybe because it's poor insurance coverage. But vaginal DHEA actually doesn't have the box warning like estrogen does. And so a lot of the medical oncology communities prefer for you to be on vaginal DHEA for the symptoms of GSM. So for the dryness, the painful intercourse, the UTI-like symptoms. Because it is not estrogen and it's not testosterone, but it's a precursor steroid that may actually increase lubrication, mucin production, so it can help dryness. It can also increase sexual sensation and stimulation, and so it may help also low libido, right? If low libido primarily is caused by GSM. Yeah. Oh, yes,
I was
sorry.
just going to go back to the ring real quick and say it's very similar to using like a menstrual cup.
Yeah. Yeah, the thing is, I've actually never seen a menstrual cup. I know I was born in the 1980s, but it's similar, right? You just push it in, I'm assuming, you just squeeze it in the middle, and then you put it in the
Make
vagina.
sure it gets behind the pelvic bone and you're good.
Exactly, yeah, exactly. You have to go through that mons pubis to make sure that you can go all the way towards the back of the vaginal canal, which is called the posterior fornix. So that is where it sits, and that's also where the ring would sit. Yeah, good analogy. Yeah. Yeah. Oh, great question. It is not progesterone. So prasterone is different from progesterone. Prasterone is DHEA, just the generic version of DHEA. And so this acts just locally within the vagina. And progesterone that she asked protects the uterus if you were to start menopausal estrogen therapy. So these are two different compounds. No, so progesterone's primary function is to protect the uterus, right? Because if you have a uterus and you're taking menopausal estrogen by itself, estrogen can abnormally thicken that lining of the uterus and it can cause uterine cancer, right? We don't want that. So progesterone protects and balances it, exactly. But there are specific progestogens called micronized progesterone or prometrium that actually have sedating side effects. And so a lot of women use it for sleep at night. So if you're waking up from hot flashes at night or night sweats, progesterone is an option without the estrogen. Good question. They studied DHEA in breast cancer survivors, I just want to say that, and they didn't show increase in toxicity side effects, so it was safe to use even in women who were on aromatase inhibitors and estrogen blockers like tamoxifen. And it didn't increase the lining of the uterus either. So that lining called endometrium was overall nice and thin. Question.
I'm just asking for a friend.
You have so many friends here. Yeah, I love it.
If she has a pessary,
Uh-huh.
you know what they are, the Frisbee. She had a 12-pound baby. And can you use the ring above it? I mean, do you have hoops?
Oh, that's a
all the way
good
through?
question. Yeah, so no, thanks for bringing that up because I actually use this I use this clinically. So the vaginal estradiol ring, right, called E-string, the one that we've been asking questions about, that actually can be used as a pessary. So it's a pessary-like device. So it's not as robust as a true pessary for urinary incontinence or prolapse. So if you have anywhere between stages 1 to 2 prolapse, then you may actually get away with the E-string or S-string. But if you have stage 3 and 4, where you're pushing the bulge back up or the prolapse back in to the vagina, then E-string might not work. That makes sense? Yeah. Tell her you're welcome. I like what Ali described not yesterday. Oh my God, we've been in this room since yesterday. I actually really liked what Ali said earlier, that you guys are thriving survivors. And this is also how I ultimately feel about having cancer and living your life post-cancer or with cancer, right? This is the time also in medicine where there are so many options. There are so many healthcare providers who are very interested in sexual health and menopause care. You just have to find them, and one good resource is the menopause.org, right? And this is a website that also has a tab specifically for women, the public, where you can find a menopause-certified provider who you can have a discussion with about your symptoms. So maybe if you had seen your primary care and you didn't feel like you were heard, maybe, your symptoms were considered mild. Who defines your quality of life? It's you, not us, right? So I would recommend seeking out the menopause-certified providers and menopause-experienced ones, and same with the sexual health community. We have sexual health-trained individuals as well in this room, okay? So I mentioned earlier that this is your preparedness, and knowledge is power, and it does take a multidisciplinary team, right? With all of us here sharing this information, sharing our knowledge, asking great questions, right? So take this opportunity to ask away. This is your toolkit, okay? So I want to be able to share and give you more information. I can't not give a talk without promoting the foundational things, right? Like lifestyle, right? What can I do that I have control over to help manage my symptoms? And the 10 health eating guidelines actually was based on centenarians, so individuals who lived past 100 years, who lived in these blue zone areas. And this is what they did. So they ate mostly fiber in the form of plants, right? Veggies. They did a lot of fruit. They ate oily fish, 2 to 3 servings per week, not meat. Maybe they were in big saturated fat eaters, right? They limited meat, limited dairy, ate a lot of legumes like beans, didn't eat a lot of sugar, and primarily drank water. Ate a lot of nuts and seeds and all the fiber and omega-3s that came from that, and also limited overall whole processed carbs like breads, pastas, potatoes, rice, and dessert. So I always want to share this just because this is actually something we can have influence on and can have do have control over. Yeah. Yeah, great question. So I always get asked this about protein and how much protein, especially as a midlife woman. So studies and also lots of debate in the nutrition community that 1 gram of protein per 1 pound of your ideal body weight is what is recommended to, 1, increase not just your bone density, but your skeletal muscle mass. Because keep in mind that when you lose your estrogen, you also lose not just your bone mass, but your risk for sarcopenia, which is skeletal muscle loss, also increases. And the only way we can really combat that is with protein intake. And protein sources have actually the building blocks to build muscle, and that's the amino acids that come from the protein, right? And so when we're actually doing the physical work, hypertrophying the muscles, maybe at one of your rooms in your house, right? Or at the gym or in a workout class, right? Or a retreat. You're doing both. You're managing the muscles or increasing the muscle mass with the hypertrophy, with the exercise, as well as the protein. So lean protein is what I would recommend. So exercise, same thing. It's endorphins, it's meditation in motion. So find something you love and just do it. And if you don't have 30 minutes at a time, even if you have 10-minute chunks throughout the day, that's better than 0-minute chunks throughout the day, right? So you don't have to be so hardcore about this, right? Any movement is great. Okay, I am getting the warning sign that I need to stop now. So these are just a list of, again, other integrative health options. So you see mindfulness, yoga, acupuncture, acupressure. So again, I just want to make sure that you have all the tools in your toolbox when it comes to managing your symptoms, and here is a list of them. These are the vetted organizations in Midlife Women's Health that support you throughout your journey. Sorry, I know these will be available, I promise, at some point through Allie, maybe. And then there's also a few slides on books on menopause. So here is my vetted list. Books on sexual health coming up. And that is my vetted list. And books on, resources on podcasts and blogs. That's my vetted list. And then one last thing, this is my contact information if you need it. And then this QR code links to our website. We have 8 certified menopause providers at the University of Utah through our Midlife Women's Health program. And this is also an integrative medical group visit that we are also offering. So for perimenopausal and menopausal women through MenoGap. If you have any questions, feel free to reach out to me. Sorry, I know that took longer. Cool, thank you. Oh, okay.
That were sent to me. Okay, this one is about the testosterone cream, and anyways, they've heard about testosterone cream helping with libido. Is that safe for a cancer patient who had hormone receptors?
Yeah, that's, wow, a very challenging question. So we don't have studies that actually prove its safety or efficacy in breast cancer patients or breast cancer survivors. But overall, transdermal testosterone, or in the form of a gel or a cream, are safer compared to testosterone pellets or testosterone injections. But keep in mind that testosterone formulations, there is no formulation that is FDA approved for women for low libido management, okay? So for sex, or I guess desire, right? So I just want to keep that in mind. So we don't know is my response to that question. And but if it's in the form of a gel or a cream, it is a specific case where I don't see super high levels of testosterone in the bloodstream when I get blood work in these individuals using the cream or the gel. So we can assume that if you're staying within the normal range, that it's overall safe. But the ones that are going above the normal range, which we call supraphysiologic, are the pellets and the injections, which are no-goes in my world. Yeah.
Thanks. And then I have another one that says, how do you know if you are estrogen receptor positive? Is there a test for it?
Yeah, so they do this. So for oncology, they do the testing, right? So when they send your pathology or that biopsy result, they go through many testing, including not just giving you your hormone receptor status, but also oncogenic type status. Any other questions? So for those of you who need to screenshot the resources, I'm happy to go through them.
We send
Yeah,
this out to.
yeah, happy for you to send it.
So we'll send this out to everyone.
Perfect, cool.
And not a question, but just more of a comment. I know you mentioned this, but for those that are interested in Veoza, make sure that you go to their website. It took it from $800 a month to nothing to use their coupon for the first year. So it's not something that most of the health insurances are covering right now.
Correct, yeah. Thank you for sharing that. Yeah, it's about $550 wholesale acquisition cost without going through insurance. Any other, oh. Are you accepting patients? Yeah, I am. The problem with that is a pretty long wait list of people, but I do have a physician assistant we hired in October who is accepting new patients as well. And so for those of you who can't physically wait 8 to 9 months for a new visit, then Dr. Anna Nash would be the person for you to see. And she actually has a PhD in sexual medicine as well. So she is menopause trained, but also is sexual medicine trained. Hopefully I will be hiring more by this fall. And so we're continuing to expand our clinical team. And so me personally, probably will be a little bit longer, but I know some of my colleagues are also booking out at least 4 to 5 months as well. So we're trying to figure out that issue of wait time and access. Yeah. But you can, this QR code can take you to our website, and then there is that 801 number to call. We don't actually need referrals from your primary care. Anyone can schedule a visit with any of our menopause-certified providers.
And may I just comment on the power of advocating for yourself? I'm 54 years old, I've had 4 children, I've had 2 pubovaginal sling surgeries, I've had postpartum depression and suicidal ideation, I've had breast cancer. Never once in my adult life have I ever had my primary care provider or any of my medical providers ask about my sexual health or my spiritual health. I have always had to bring it up myself. So I just want to say about the power of doing your own work, like researching, reading about what you want to know about, but then asking and starting the conversation, because sometimes they just don't start the conversation. But if you do, there's information there.
Thank you for sharing that, Susan. That was beautiful. And one more question.
Is there any value in measuring your estrogen levels? Sometimes when you have estrogen positive cancers, it's just a cookie cutter. You're going to be on aromatase inhibitor or tamoxifen. And I honestly feel like those drugs have put me in megapause, not just menopause.
Sure.
So is there any value in knowing what your levels are instead of just giving you pills?
Yeah, great question. So this is where talking to you and the symptoms related to potentially menopause, right, estrogen loss would be more valuable than levels. We don't treat to target value, we treat to how you're feeling, right? So asking you specific symptoms, last time 6 months ago when we had the conversation, you mentioned sleep was really bad. How is your sleep now? And that's when I know things are working or things are not working. And so some people do get estradiol levels just because, one, they are on treatment, or maybe you are on menopausal estrogen therapy and you're on one of the higher dosing of menopausal hormone therapy and your symptoms are still quite there, and so they don't really coincide with the dosing that you're getting. I would be curious to know if you're actually absorbing the estrogen, and that's when I would check the estradiol level in that case. But, if you are in front of me, we're talking symptoms, that's what I care more about instead of levels. But there are other helpful levels to get. So thyroid disorders often mimic menopausal symptoms, so making sure you get your thyroid screening done, right? I mentioned iron deficiency anemia causing restless legs, so getting your anemia levels done, and also your metabolic labs, right? So cholesterol, diabetes, those are important as well, because those can cause random symptoms related to hot flashes, right? So, and keep in mind, medication side effects can cause hot flashes, not just estrogen blockers. There's beta blockers that cause hot flashes. There's actually Effexor can cause hot flashes. Lexapro can cause hot flashes. Those are antidepressants I mentioned earlier that are used for hot flashes, but can also cause them, unfortunately. So keep that in mind. Looking at your medication list, whether it's prescription-based or over-the-counter supplements, can cause these symptoms. Any? Great, yeah, thank you.